Hello everyone. Today the topic of discussion is oncology part 2. In part 1 we are, as you all know, we are doing a revision series. In part 1 we did the cancer cervix screening, because cancer cervix is the most common genital cancer of the female, and it is the second most common cancer of females. So screening is must for female, and we discuss in detail how we will interpret the report of screening and how which population we will target in screening, and how to do the screening, right? So now we will do the cancer, including now we will do the cervical cancer and ovarian cancer and the endometrial cancer simultaneously. Okay, so let's start. So first of all, I want to tell you that first time the patient come to us in the OPD. Okay, and what is cancer? You all know, in cancer the cells multiply abnormally, right? And in cancer cervix will multiply abnormally, right? So the latent phase of the cancer cervix, that is, what is latent phase? The time period which is between the pre-malignant stage. What is the pre-malignant stage of the cancer cervix? Cervical intraepithelial neoplasia. The time taken from pre-malignant state to the malignant state, or the cancer cervix carcinoma, okay, is 15 years. Okay, it takes 10 to 15 years. Okay, it's quite long. So it might, so whenever you will see the cervix, it can be there that the cervix is healthy, and the patient has the cancer in between the in the cervical epithelium cell. That is why screening is so successful in cancer cervix. Okay, so what symptoms do you think when those cervical cell will rapidly divide? What symptoms do those rapidly dividing cervical cell will give? Okay, first of all, most common symptom with which the cancer cervix patient present is irregular bleeding. Okay, irregular bleeding, spot occurs anytime. Okay, irregular bleeding, or, and the most specific is post coital bleeding. During the coitus, cervix faces the friction. ठीक है. So there is a post coital bleeding. So most common symptom with which the CA cervix present is irregular bleeding. This is the most common. And post coital bleeding, I have written here PCB, but it means post coital bleeding, and it is a more specific symptom. Okay, if the patient has presented to us late, then there can be unhealthy cervix. Okay, then there can be unhealthy cervix, or there can be cervix growth also. Okay, it is not essential that always in the case of the cancer cervix you will find unhealthy cervix or cervix growth, because the latent phase of the cancer cervix is very long. It is 10 to 15 years. Okay, it can be that patient only present with symptoms. It can be that the patient presents with both unhealthy cervix and symptoms both. Okay, now what happens in cancer endometrium? How the cancer endometrium patient present to us? In cancer endometrium, the endometrium rapidly divide, right? So what complaint will the cancer endometrium patient give to us? We have studied that cancer cervix population is 21 to 65. And what is cancer endometrium? It is perimenopausal, 45 to 65, or more specifically you can say 50 to 65. Okay, so now that is the time of menopause. So these ladies who are having cancer endometrium will have hyper proliferated endometrium, right, or hyperplasia of endometrium. And what is a pre-malignant condition? Hyperplasia is a pre-malignant condition of cancer endometrium. So due to the increased proliferation of the endometrium in the cancer endometrium patient, the patient is going to suffer from menomatorrhagia. What is menomatorrhagia? What is menomatorrhagia? Menomatorrhagia is irregular bleeding, spotting, you can say, irregular bleeding, plus what is plus menorrhagia. So heavy cycles and heavy bleeding during the cycles, and there is irregular bleeding also, okay, in between the cycle. So this is the most common complaint of the patient who are having CA endometrium. If a 50-year lady come to you with these complaints, you will suspect at cancer endometrium, okay. Then the another complaint is prolonged cycles. Now it is not prolonged cycle, it is prolonged bleeding, so, or menorrhagia you can also say, okay, prolonged bleeding cycles. Or the patient, if that patient has achieved menopause, then this patient can also present to us as post menopausal bleeding. Patient can also present to us as post menopausal bleeding, okay. Patient can also present to us as post menopausal bleeding, okay. Now let us see how the, because endometrium will proliferate and then the patient will suffer from post menopausal bleeding. Now we will see how the patient of ovarian tumor presents to us. Okay, now ovary will rapidly divide, ovarian cells will rapidly divide, so there will be a large adnexal mass. Ovarian tumors are largest tumor of the mankind, okay. So there will be a large adnexal mass, and due to that mass, patient will have pain abdomen or pain in the pelvis, right? Now body is consuming its own proteins to make that content of adnexal mass. To make that content of adnexal mass, body is consuming its own proteins, its own nutrients, okay. Now if excessive proteins are being consumed, then body will go into the hypoproteinemia and the patient will get ascites, okay. So one thing I have already told you in the ovarian tumor class, more is the more large is the mass, lesser are the chance that ovarian tumors will be malignant, because a small malignancy can do a hell to the human, right? Can do a hell. Malignancies have worse prognosis, malignancies have a poor prognosis. So it is benign only, that is why it is growing and the body is not getting affected, okay. So here you will see that in the ovarian tumor we are doing biopsy in the last, okay, whereas in the CA cervix and CA endometrium we are doing biopsy very early, okay. So that is why we will use the word ovarian tumor, because in the last we come to know whether it is benign or malignant, okay. And CA cervix and CA endometrium we do biopsy, you will see, in starting only, okay. So we will use the word ovarian tumor in the case of ovarian. So mostly they are cystic, and ovarian tumors, they are cystic, and as more and more body protein is consumed, more and more the body suffers from hypoproteinemia and ascites, hydrothorax all occurs. And we will confirm our finding by ultrasound. Already discussed, ultrasound will have multiseptate and multilocular if that ovarian tumor is malignant, okay. Now let's see this questions now. 60 years old lady with diabetes mellitus and hypertension has presented with post menopausal bleeding. Next step or first step, okay. Now this lady is diabetic mellitus and hypertension, and this lady has presented with post menopausal bleeding, okay. Now first step, you know that CA cervix can also present with postmenopausal bleeding. Already cleared in first video itself that most common cause of postmenopausal bleeding in India is CA cervix. So first step or the next step will be to rule out the most common cause, and the most common cause is yes, CA cervix. So how we rule out CA cervix? So first step is pap smear. The first step is pap smear. Okay. Next, 35 years lady with post-menopausal, uh, okay, it is post-coital bleeding. 35 years lady with post-coital bleeding. Okay. Now, you know that post-coital bleeding, again, it is most common cause of post-coital bleeding. Already we have studied in the first part. Okay, first slide it was that most common cause of the post-coital bleeding is, yes, CA cervix. And what is the test for CA cervix? Pap smear, right? Are you getting the symptoms? Okay. History of post-menopausal bleeding. On examination, cervix is hypertrophy and cervix erosion is present. Now here, beta, cervix is unhealthy. Now it gives us a suspicion of it gives us a suspicion of cancer cervix. Cervix is unhealthy, plus the lady is having postmenopausal bleeding. Now, when we are getting a strong suspicion by unhealthy cervix, then we will not do screening test. Here in this question, where 60 years old lady was having postmenopausal bleeding, no unhealthy cervix was written. If it is not written, it is assumed that cervix is healthy. If here also no unhealthy cervix was written, if it is unhealthy, it means, if it is not written, it means it is a healthy cervix. So in the healthy cervix, in postmenopausal and most coital bleeding, we will do pap smear. And if the cervix is unhealthy, then we will do the confirmatory test. Though the confirmatory test for cancer cervixes is colposcopy biopsy, but here we will do 4 quad biopsy. Okay. 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 Most common symptom of cancer cervix, can anyone tell me? Irregular vaginal bleeding. Okay, irregular vaginal bleeding, and more specific was postcoital bleeding. Okay, see this next question. 55 years old lady presented with abdominal distension. So ovarian tumors, they present with abdominal distension. Now you know that adnexal masses. Okay, pelvic pain and clinic CE means clinical examination. Clinical examination shows ascites and CA 125 is high. Okay, what is the diagnosis? What is the diagnosis? So now CA 125 is the tumor marker of ovarian tumor. So answer is ovarian tumor. Okay. Now you have seen what are the clinical presentation. I will again summarize it for you. Cancer cervix present with irregular bleeding or postcoital bleeding or postmenopausal bleeding. Okay. Then cancer endometrium present with menometorrhagia, prolonged bleeding cycles, or you can say menorrhagia or postmenopausal bleeding. Okay. Ovarian tumors, they present with adnexal masses, and if they are large enough, they can cause ascites also. Okay, and the findings are confirmed on ultrasound. Okay, now we will simultaneously study the risk factors of all the 3 cancer. Now we have studied that cancer cervix is caused by human papilloma virus. Okay, and how human papilloma virus, when human papilloma virus infects the transformation zone, it infect during the intercourse. It comes from the male partner of that female. Female is not having human papilloma virus. A lady who has never done intercourse will never get CA cervix. So CA cervix is due to human papilloma virus, and human papilloma virus infection is from the male partner of the female during the intercourse when human papilloma virus infects the transformation zone. Okay. Now it means that when a lady with the symptoms of cancer cervix is coming to us, irregular bleeding, postcoital bleeding, postmenopausal bleeding is coming to us, then we, or unhealthy cervix is coming to us, then we have to rule out its risk factors. So all the risk factors are related with the sexual activity of that female. Okay. So for what parameters we have to ask which will tell how active sexually the female is? First of all, what was your age of first sex? Okay, early age sex means more exposure to human papilloma virus. More is the sex, more is the CA cervix. So early age sex before 18. Okay, then child in early age on multiparity. Okay, more is the sex, more are the child formed, right? Then multiple sexual partner. If HPV doesn't come from one partner, it will come from another. Multiple sexual partners. Okay, woman with STD. If a woman is having sexual transmitted disease, it means the woman has got is prone to this STD also. Okay, low socioeconomic status, smoking, alcohol, IV drug abuse. So all these factors are also increased with increased sexual activities. Immunocompromised, one who is immunocompromised is more prone to infectious. Okay, so these are the parameters which we will rule out while we suspect the patient due to symptoms and sign. Okay, for example, a lady comes and complain, I have postcoital bleeding. You examine the patient and you saw something unhealthy cervix, then you will ask this history. You will rule out the risk factor. More are the risk factor, more are the chances of the cancer cervix. Now, what if the patient of menometorrhagia or menorrhagia or postmenopausal bleeding comes to us? We will suspect the cancer endometrium. Okay. Now we know that cancer endometrium is due to endometrial proliferation, and endometrial proliferation is due to increased estrogen. So all, or you can say unopposed estrogen. What is the function of progesterone? First 14 days estrogen proliferates the endometrium, and what does progesterone does to that endometrium? It stabilizes it. What is another name of stabilizes? Stops the proliferation and make the endometrium secretory. So unopposed estrogen in which no progesterone is there, estrogen is proliferating, no stoppage. So whenever there is more, the condition in which there is more endometrium proliferation or more estrogen exposure, more estrogen means more endometrium proliferation, and unopposed estrogen, then there will be increased chances of cancer endometrium. Cancer endometrium, you have also to rule the family history, because hereditary non-polyposis colon cancer syndrome is associated with endometrial cancer also. What are the another name of HNPCC? Lynch syndrome. What are the 4 cancers which are associated with HNPCC? Colon cancer, endometrial cancer, ovarian cancer, and breast cancer. So you have to ask these 4 cancers family history to the patient of in which you are suspecting endometrial cancer who has come with menometorrhagia. So you have to ask these histories to the patient so that we can rule out and save the other family members simultaneously. Okay, you can get more patients if you get any of this history. You can explain that you can transmit, these members can also have. Okay, so what are the factors in which your body is exposed to more estrogen or more endometrial proliferation? Okay, so one is tamoxifen. tamoxifen is very commonly being asked in the last FMG exam. It was asked tamoxifen is some selective estrogen receptor modulator. It is estrogenic on breast. Sorry, it is anti-estrogenic on breast and it is estrogenic on endometrium. So it is given in the breast cancer because it is anti-estrogenic on the breast, but it is estrogenic on the endometrium. So a breast cancer patient who is having tamoxifen is prone to endometrial cancer because this estrogenic action on the endometrium will increase the proliferation, okay, of endometrium. HRT, in HRT we are giving excess of estrogen, so HRT prones a patient to estrogen, endometrial cancer, okay. Early menarche, more early is the menses cycle, more early the endometrium proliferation will start. So early menarche, late menopause, simultaneously you should say them, early menarche, late menopause, okay. More late is the menopause, more the body is exposed to estrogen, more is the estrogen, more is the endometrial proliferation. Next is nulliparous. Now pregnancy gives rest to endometrium proliferation because when the fetus is there in the uterus, no proliferation is there, and there is again no proliferation during the lactational amenorrhea also, okay. So again these symptoms, yes, should be asked. These risk factors should be, if the lady is nulliparous, it means no rest to endometrial proliferation, it means the lady is prone to endometrial carcinoma, okay. Now why in obesity, diabetes and hypertension the lady is prone to cancer endometrium? Because more is the obese lady, more is the chances of diabetes and hypertension, okay. So these are related with diabetes and hypertension are related with obesity. You all know, you are a good medicine students, right? Now you tell me ki why the obesity is related to endometrial cancer. More is the patient obese, more is the cholesterol, more is the cholesterol, more is the estrogen formed, that is why, okay. So more is the estrogen, more is endometrium proliferation, okay. PCOS, what is PCOS? In this, ovulation does not occur, so endometrium keeps on proliferating, no corpus luteum is formed, no progesterone is there, right? So endometrium keeps on proliferating. So you can understand that in PCOS, because unopposed estrogen is there, prolonged endometrium keeps on proliferating. So PCOS is a risk factor for endometrial cancer carcinoma. Granulosa cell tumor, what is granulosa cell tumor? We will discuss it after a while. In granulosa cell tumor, the granulosa cell of the follicle or the follicle of the ovary has two type of cell, granulosa cell and theca cell. The granulosa cells, they secrete, they get tumorous. So function of granulosa cell is to secrete estrogen. So when there is granulosa cell tumor, more and more estrogen will be there and more endometrial proliferation is there, okay. So in short, you have to, whenever the list is given there in the exam, you will see that whether these factors are proning the patient to increase estrogenic conditions or not, okay. Excess endometrial proliferation on, and whether the patient all these conditions, okay. So you will rule out whenever a patient of menometorrhagia will come, you will rule out whether this patient has any excess estrogen condition. What are the excess estrogen condition? Two drugs, tamoxifen and HRT. Other conditions are early menarche, late menopause and nulliparous. And then third is obesity, diabetes mellitus and hypertension. And when obesity, diabetes, sorry, there is one syndrome you should know, question can come on it. Corpus cancer syndrome. Corpus cancer, corpus means body, cancer means endometrial cancer, syndrome, when we say it, corpus cancer, when there is diabetes, when and hypertension and endometrial cancer. Okay, and endometrial cancer, when these conditions are there, then it is known as, yes, then it is known as, yes, corpus cancer syndrome. It is quite often seen. The lady who is having endometrial cancer, most of the time that lady suffers from diabetes mellitus and hypertension also. Okay. Okay. Now let us study what are the risk factor of the tumor, ovarian tumor. Okay. First of all, you should know that the risk of ovarian tumor increases to 50% in a patient who is having BRCA mutation. What is BRCA mutation? BRCA gene, if it get mutates, BRCA1 and BRCA2 it get mutate, then the lady is got an increased risk. So how you will rule out that the lady is having or not BRCA mutation? You will ask to which two cancer is the lady prone to if the lady has BRCA mutation. They are the ovarian cancer and breast cancer. Okay. So you will ask whether your first degree or second degree relatives are having this cancer or not. Okay. And again you will rule out HNPCC cancers also. What are the four HNPCC cancer? Colon cancer, endometrium, breast and ovary. Okay. Now epithelium ovarian tumors, they have more risk factors also. Okay, so if you are suspecting epithelial ovarian tumor, then you have to rule out more risk factors also. What are they? Because the function of epithelium is to rupture when ovulation occur. So whenever there will be more ovulation, all those factors which cause more ovulation will prone the patient to ovarian tumor. Okay, will prone the patient to ovarian tumor. What are the factors which prone the patient to increase ovulation? Same in early menarche, late menopause, nulliparous. Early menarche means early ovulation started. Late menopause means late ovulation stopped. And the nulliparous, no stoppage of ovulation during the pregnancy, ovulation stops. So nulliparous is prone to ovarian cancer. Asbestos, talc. Yes, the perineal tract contains a component asbestos which prones the lady to ovarian cancer. Now, a lady who is undergoing infertility treatment quite often takes ovulation induction drug, and ovulation induction drug increases the ovulation. Okay, ovulation induction by the HCG, it increases the once in a month 15-16 ovulations are there. Okay, so the lady who has taken the ovulation drugs or has undergone the ovulation infertility treatment is prone to ovarian tumors. Okay. Okay, so what are factors which you are going to rule out in the ovarian tumor? BRCA mutation and Lynch syndrome cancers, hereditary cancers, and increased ovulation factors. What are the factors which you will rule out in cancer cervix? We will rule out the increased sexual activity and immunocompromised status. In the cancer endometrium, we will rule out the Lynch and syndrome cancers, for hereditary cancers, and we will rule out the increased endometrial proliferation factors, tamoxifen HRT, early menarche, late menopause, nulliparous, obesity, diabetes mellitus, hypertension, PCOS and granulosa tumor. In the ovarian tumor, we will rule out BRCA mutation, Lynch syndrome, and early menarche, late menopause, nulliparity, and ovulation drugs. Now, I hope you understand all these factors. Now, let's do questions. Patient with breast cancer on tamoxifen present with abnormal vaginal bleeding. What is the cause? Now, this abnormal bleeding is due to the tamoxifen. So, the cause is endometrial cancer has developed. Okay, it is not cervical cancer, cervical polyp. Tamoxifen has no effect on cervix, and tamoxifen never causes fibroid. Okay, next question. Risk of endometrial cancer is least they are asking. Positive family history, yes. Which syndrome you will rule out? Lynch syndrome. Okay, which in late menopause more endometrium proliferates. In obesity more endometrium proliferates due to increased estrogen. Multigravida rest to endometrium proliferation. Answer is this. More is the lady pregnant, more is the rest to endometrium proliferation. Answer is multigravida. Next, all are risk factor of endometrial carcinoma. Risk factor of endometrial carcinoma are those which proliferates the estrogen more. See, granulosa cell tumor. So in granulosa cell increase estrogen is there. So it is right. HRT, it is increased estrogen is there. It is correct. Smoking. So smoking increases everything except endometrial carcinoma. Now we will see how the smoking decreases. You know, we have read in contraception that smoking does endothelial dysfunction. In the same way, smoking destroys the endothelium of the endometrial cells, and that is why endometrial does not proliferate. So smoking is protective only in one diseases, that is endometrial carcinoma. It doesn't mean that you females will start smoking. Okay, smoking is protective in endometrial carcinoma. Okay, next factor is tamoxifen. Tamoxifen always increases the endometrial proliferation. So answer to this question is smoking. Smoking is protective only in one medical condition, that is the endometrial carcinoma. Can you tell me one thing now? Smoking is hampering infertility or promoting? Smoking will increase the fertility or decrease the fertility? I'm not talking about infertility, I'm talking about fertility. Fertility of the woman gets decreased because endometrium and the ovum, they get destroyed due to smoking. Okay, 37 years old lady on OCPs. Her mother had breast cancer at 55 and sister had ovarian cancer at 45. Now they are telling you that the 37 years lady was on OCP, oral contraceptive pills. Her mother had breast cancer at 55 and sister at 40. Next step, now this lady has come for the cancer screening to you. Now will you, what are you suspecting? Early age of the breast cancer and early age of the ovarian cancer. This is a case of Lynch hereditary cancer. This lady too can suffer. So what is the next step? Genetic testing and BRCA testing. Why? Which genetic testing? Lynch syndrome. It can be Lynch syndrome or it can be BRCA mutation. So these two should be ruled out. Okay. Now next question is, answer is of course first. Let us see the other. Stop OCPs. Why to stop OCP? Already in contraception I have discussed in detail that while taking OCPs, HPO axis is suppressed, no natural estrogen is not released, body is only dependent on external estrogen. The external estrogen levels are low, very low than the normal estrogen levels. So low estrogen means low endometrial proliferation. Taking oral contraceptive pills prevent endometrial cancer, and they also prevent ovarian carcinoma, because no ovulation, no epithelial ovarian cancers. Okay, so why to stop OCPs? No, not to stop OCPs. OCP should be given. Okay, mammogram every year. Mammogram every year, no. Mammogram every year can help us to screen, but the cancer, if there is BRCA mutation, then the chances of ovarian cancer and breast cancer are 50%. Okay, so mammogram is not going to help. Prophylactic surgery, what if the BRCA mutation is negative and we have done the prophylactic surgery? Right, we should do the prophylactic surgery only and only if there is BRCA positive or there is any genetic Lynch syndrome positive. Okay, next is all are risk factor for the development of ovarian cancer except use of OCP pills. They are repeatedly asking you these questions because you people get confused. Taking OCP prones the patient to cancers. No, no, no. Taking OCP decreases the chance of endometrial cancer and ovarian cancer. So all are the risk factor for development of ovarian cancer. OCPs, no, they don't want increase. Next, second is use of clomiphene. Yes, ovulation induction drug clomiphene will increase the chance. Family history of ovarian cancer, yes. Lynch syndrome and BRCA mutation. Then again BRCA1 mutation, yes. Okay, so this will not increase the risk. Now a patient has come to you with the symptoms of cancer cervix, one patient has come to you with symptom of cancer endometrium, and one patient has come to you with ovarian tumor symptom. So in cancer cervix, patient has come to you with abnormal vaginal bleeding and postcoital bleeding. In cancer endometrium, patient has come to you with menometorrhagia, and in the cancer ovarian tumor, patient has come to you with abdominal distension and ascites. Now how you are going, now you have ruled out the risk factors. Okay, how you will now confirm that whether the patient is having or not? You will do the confirmatory test. Okay, confirmatory test. No one of you will do the screening. Now patient is the suspicious patient. Okay, okay. Cancer cervix colposcopic. What is the test of the cancer cervix confirmatory test? If on cervix you are not seeing any growth on the cervix or any lesion, then you will do colposcopic. You will find the lesion. Okay, by colposcopy. Okay, if you are not able to find the lesion, proper lesion, in general the whole cervix is congested, is eroded. Okay, then you will find the lesion with colposcopic guided colposcopy. Okay, and then you will take the punch biopsy. Okay, from that lesion site. See, for example, if I will tell you in which question we studied the biopsy. Yes, in this question. See, what was the finding? History of post-menopausal bleeding on examination. Cervix is hypertrophy and cervix erosion. So this is an unhealthy cervix. Now you have to find you. Now you know that this patient is having unhealthy cervix. This patient is having post-menopausal bleeding. This case is, now you will not do pap smear in this. This is a suspicious patient. Okay, now you cannot find the lesion. You are seeing that whole cervix is hypertrophied, whole cervix has got erosion. Now where to take the biopsy? You cannot cut the whole cervix and go for biopsy. No, you cannot go. So you will do the you will find the lesion by colposcopy. So whenever you have to find the lesion, you will find it by colposcopy. Okay, That is why it is a colposcopic guided. Then when you have find the lesion by colposcope, then you will take the punch biopsy from that lesion. Okay, and or if you are finding any growth on Telegram, I have posted the growth. If you are finding such a beautiful growth on the cervix, then you will take the punch biopsy direct. Either you will go for the colposcopic guided punch, you will find the lesion by colposcope, and if you already have that lesion, then what you are going to do, you are going to take the punch biopsy direct. Okay. Then if the patient, you are suspecting cancer endometrium, patient is coming with menometorrhagia, okay, and you find the patient is diabetic, you find the patient is hypertensive, you find the patient is with such problems, you suspect that yes, this is cancer endometrium. So then what? Then you will do the endometrial biopsy. Okay, so here also we are doing biopsy, here also we are doing biopsy. Okay, if we do it with a Pepley instrument, it is known as Pepley biopsy. If we do it by hysteroscope, it is known as hysteroscope biopsy. Hysteroscopic biopsy is best. Okay, we can also do fractional curettage or DNC, but hysteroscopic biopsy is best. When office biopsy or Pepley biopsy is the easiest to do. Now, if the patient is presenting with such abdominal distension and BRCA mutation, you rule out, you get a BRCA mutation in that patient. Now what you will do, you have confirmed the finding of you have got the ultrasound done and confirmed your adnexal mass finding. Now you will not do any biopsy, now you will send the tumor marker. Okay, now you will send the tumor marker. In ovarian tumor, we don't send the biopsies, we send the tumor marker. We send the tumor marker. We send the tumor marker. Okay. Okay, we will discuss this tumor marker. Let's study. 52 years old lady present with post-menopausal bleeding. What is the most common cause of post-menopausal bleeding? Cancer cervix. On examination, cervical growth is present. What is the next step? Colposcopic biopsy. Why? Colposcopy we do to find the lesion. Growth is there in front of us. So, no option of colposcopy biopsy. We will do the biopsy of the lesion. Pap smear, already cervical growth is there. No other reason is there for the cervical growth. Why pap smear? Punch biopsy? Yes, this is the answer. Excision of the growth and reassure? No, cancer is there. Not reassurance. So answer to this question is punch biopsy. Next question. History of cervical postcoital bleeding. Now postcoital bleeding is there. Postcoital bleeding is a symptom of cancer cervix. On examination, cervix hypertrophy and cervix erosion. Unhealthy cervix is there. Next step. Okay, biopsy should be there. Ideal answer is colposcopic biopsy, but since it is not given, so we will mark the 4-quadrant biopsy. Next, colposcopic guided punch biopsy. So what is colposcopy? Colposcopy is basically a camera plus a magnified lens. Okay, we see the cervix by magnification. Okay, so if there are small ulcers which cannot be seen by the eye, then we can see it. Okay, so basically what is colposcopy? Colposcopy is seeing the cervix with the magnified image, and then we will do 3-4 measures to see the rapidly dividing cells or the cancerous cells. First measure is we see the magnified image, okay, and see the whether there is any ulcer is present there or not. Okay, of course magnification will tell us the better result. The another measure is to apply the Schiller iodine. Schiller iodine Schiller iodine, if the glucose is present in the cells, then the cells are stained brown with the mahogany brown. What is mahogany brown color? See, if this is the cervix, we will stain this cervix with Schiller iodine. Now this I have applied Schiller iodine. Now whole cervix Wix has turned mahogany brown. It means that there is no cancer, because cancerous cells, they don't have glucose. They consume their glucose in division. Okay. Now because all the cells are stained mahogany brown, it means here no cell is deprived of glucose. They are having glucose. If the if it would have been, if it would have been cancerous cell, suppose this area was cancerous, then this area would be stained mustard yellow, like this. If any this mustard yellow area comes, it means it is a cancerous, because here there is no glucose. If glucose is present, then it will be the mahogany brown. If it is mustard yellow, it means it is cancerous with the Schiller iodine. Then again we can apply the on the cervix acetic acid. Okay. See, if this is cervix and we have up, this is cervix, cervix is of red pink color, right? And if we will apply the acetic acid, suppose we have applied the acetic acid on the cervix, and if we saw any white areas on the cervix, then if there is increased protein in the cells, then the acetic acid will coagulate that area, and that area will look white, because increased proteins, when they will get coagulate with the acetic acid. When where there is proteins in the cell, increased protein in the cells, in the rapidly dividing cells, rapidly dividing cells have less glucose and increased protein. Okay. So how will the area look if it is cancerous? How will the cervix look if it is cancerous? Yes. See, this is the cancerous part, aceto white. Okay. Now we will apply the green filter. In the next step we will apply the green filter. What is green filter? We will throw the green light. For example, this is cervix and we have thrown the green light. Now under the green light, the blood vessels, they look white. Okay, under the green light, the blood vessels, they look white. Okay, if this is the cervix and we have thrown the green light, now these if the blood vessels are present, then like this, the area which is cancerous will have blood vessels. So like this, we will see under the green light, we will see the blood vessels as white lines. Okay. So white lines indicates neovascularization, which is present in cancerous area. So now after doing this 4 maneuvers, what are the 4 maneuvers? Yes, the 4 maneuvers are: first is the magnified view, second is the Schiller iodine, third is the acetic acid application, fourth is under green filter. By these 4 maneuvers or measures, we will know where the lesion is. And now we have come to know that the lesion is here, right? This is a lesion area, this is a lesion area, and this is a lesion area. Now we will take the punch biopsy from this area. Okay. Okay. Here we studied that the confirmatory test was punch colposcopy, guided punch biopsy. If we are not finding any lesion, we have studied colposcopy punch biopsy. And in the ovarian tumor, we have to send tumor marker, right? So what are the tumor marker and what are the different ovarian tumor type that should be known to us? So let's study that. What are the different type of ovarian tumor and what are the ovarian tumor markers? Okay. So first of all, there are 3 type of cells. See, if this is ovary, this outer covering is known as epithelium. The ovary has many follicles. This is known as follicle, and it contains germ cell or ovum, and this is the germ cell. 3 cells, 3 tumor. Epithelial ovarian tumor, germ cell tumor, sex cord or follicular cell tumor. Already discussed, follicular cells are also known as sex cord. Okay? Till now we haven't done any biopsy, so will not say it cancer. We will say tumor because we haven't done any biopsy. Okay? So epithelial ovarian tumor is the most common tumor. It is present in 90% of all the tumors are epithelium ovarian tumor. Again and again I am telling you in every class, the most common tumor are the epithelial ovarian tumor. Germ cell and sex cord tumor are the least common tumor. Okay, they are only 5% or 3% like this. Epithelial ovarian tumor are 90% of all the ovarian tumors. Okay, and epithelial ovarian tumors occur in 55 years, 50 to 60 years. Okay, perimenopausal or menopausal lady. Okay, the tumor marker of epithelial ovarian tumor is CA125. CA125. Depending on what is that tumor's content, the epithelial ovarian tumor is divided into 5 types: serous, mucinous, Brenner if it is solid, rubbery, endometrioid and clear cell. Okay, you have to learn this: serous, mucinous, Brenner, endometrioid, clear cell. Okay. Okay, and the tumor marker is CA125. Okay, now this was about epithelial ovarian tumor. So if you are getting a tumor or an adnexal mass in 55 years old lady, so you will send the tumor marker CA125. Okay, okay. If you are getting a tumor in 25 years female, then you will suspect germ cell or sex cord or follicular cell tumor. If you are getting the adnexal mass in 25 years female, then you will suspect germ cell or the sex cord tumor. What are different type of germ cell? Let's see, already discussed in previous class. If this is germ cell, then it makes 3 things: fetus, yolk sac and placenta. If the part which is making the fetus get tumorous, then it is known as teratoma. Teratoma. And this is the most common germ cell tumor. In this tumor, we find hairs, we find teeth, we find thyroid tissue, all the 3 germ cell structures we find, and this is what it is asked in exam. It is also known as dermoid cyst. If on the so in the ultrasound itself, the radiologist write there कि a dermoid cyst containing hairs, containing this mesodermal, ectodermal and endodermal structures are found. Okay, if it is a yolk sac tumor, okay, then as you know, yolk sac functions perform the functions of the liver. So tumor marker alpha fetoprotein is raised. Alpha fetoprotein. If the part of the germ cell which is making placenta gets tumorous, then non-gestational trophoblastic neoplasia or choriocarcinoma is formed. This time the lady is not pregnant. So it is known as non-gestational trophoblastic neoplasia, and the tumor marker of it is HCG. Okay, and the tumor marker of it is HCG. Okay. Next, tumor. Now you know that one thing is germ cell or the germ cell tumor we have done. Another thing is primordial germ cell. If the primordial germ cell become tumorous, then dysgerminoma is formed, and now it is very dangerous tumor. It is equal to the seminoma that you find in males, and the tumor marker of it is LDH, and it is the most common malignant germ cell tumor. If it is asked most common malignant ovarian tumor, it is serous epithelial ovarian tumor. Out of the all epithelial ovarian tumor, serous tumor is most common. If it is asked which is the most common malignant germ cell tumor, then it is dysgerminoma. And which is the most common germ cell tumor? It is teratoma or dermoid cyst. Now, if the 25 years lady is female is having increased estrogen features, then it is a granulosa cell tumor. It means it is a follicle cell tumor. Follicle has two type of cells, granulosa cell and theca cells. Granulosa cell function is to secrete estrogen, so it means that estrogen is increased. They also synthesize inhibin B, so inhibin B is also increased. Okay, so I think now you can understand that why precocious puberty, menorrhagia occur due to the increased estrogen in the follicular cell tumor, and the tumor marker of it is inhibin B. Okay, and the patient of the, there is another sex cord tumor, that is fibroma. The patient of the fibroma suffers from Meek syndrome. Few minutes later we will see what is Meek syndrome. Okay, so what all are the tumor marker? Tumor marker of epithelial ovarian tumor is CA125. If 55 years lady come to you, you will send the CA125. If 25 years old lady comes to you, then you will send these tumor marker: alpha fetoprotein, HCG, LDH. If the lady comes to you with increased estrogen features, then you will send the inhibin B. Okay, now let's do question. Okay, most common malignancy of ovary. Okay, serous cyst adenoma. Please, no one of you will mark granulosa cell tumor. Again and again I am telling you, which is not a germ cell tumor. Germ cell tumor were if teratoma, yolk sac tumor, non-gestational trophoblastic tumor, or choriocarcinoma, and the last was dysgerminoma. So granulosa cell tumor is a follicular cell tumor or sex cord tumor, because granulosa cell is the cell which makes the follicle. What is Meek syndrome? Again and again I am telling you that Meeks in the ovarian tumor, body is utilizing its own nutrients. So Meeks syndrome is basically the syndrome which is associated with fibroma. Okay, so benign fibroma is there. They have asked there whether there is benign fibroma or malignant. So there is benign fibroma. Why? Because if it is benign, then only it will grow so large to do ascites and hydrothorax. If it is malignant, only when it is small, only it will give a hell to the body, right? So answer to this is benign fibroma, because body utilizes own protein, so body goes into hypoproteinemia and large ovarian tumor fibroma is formed, ascites and hydrothorax. And now you know that ovarian it is a fibroma is a sex cord tumor. Okay, now we will interpret how to interpret the confirmatory reports. In the cancer cervix patient in which we saw that growth on the cervix, we have sent the punch biopsy. Now it can be there that the patient not having cancer, and the patient is having pre-malignant lesion, right? If the patient is having the pre-malignant lesion on the punch biopsy, it is confirmed. It is not the pap smear report that we have to confirm with biopsy. It is a biopsy report, punch biopsy report. It is confirmed. Now we have to, if it is CIN 2 and 3, we have to do LEAP. If it is invasive cancer, we have to do conization. What is conization? Conization means is to remove the cone of the cervix. Okay. If it is, what is invasive cancer? If it has invaded the basement membrane. Okay. If it is CIN2 and 3 confirmed on the punch biopsy, it is LEAP. What is LEAP? Laser excision of that at area. Laser excision. Electric excision. Okay. And if on the punch biopsy it comes squamous cell carcinoma, then next is we will do the clinical staging. Okay. So all the genital cancers have got the surgical staging except cancer cervix. In the cancer cervix we do clinical staging. We will examine the patient and we will find which stage it is. Okay. Okay, so we will designate the stage to the patient. In the endometrial biopsy, it might be that the patient have pre-malignant lesions. So what are the pre-malignant lesion? Hyperplasia with atypia and without atypia. It can be hyperplasia without atypia and hyperplasia with atypia. Okay, these are the pre-malignant lesion. So if the on the report it is written hyperplasia without atypia, it means cancer is not there, but no atypical cells are there, but hyperplasia has been noticed. So then progesterone is the treatment. Okay. And if the family is complete, then we should do hysterectomy even if there is hyperplasia, because hyperplasia is a pre-malignant condition. There are two types of hyperplasia: simple hyperplasia and complex hyperplasia. So in both the condition, if atypia is not there, then we have to do then the treatment is progesterone, and if family is complete, then hysterectomy. And if it is hyperplasia with atypia, then you have to undergo hysterectomy whether the family is complete or not complete. Okay. The treatment of without atypia is progesterone, and with atypia is hysterectomy. But if family is complete, here also we can go for hysterectomy. Okay, the chances of simple hyperplasia without atypia is 1%, and chances of complex hyperplasia without atypia is 3%. Complex of simple hyperplasia with atypia is 8%, and chances of complex hyperplasia with atypia is 28%. This you all know. Okay, you have mugged it very rightly. Now, if on the endometrial biopsy adenocarcinoma is written there on the report, it means now it is a carcinoma and we have to do staging. Okay, we have to treat this. How we will treat depend on which stage it is. How we do the staging of endometrial carcinoma? All cancers except cervical cancers are done by the surgical staging. Now we will do the surgery. Which surgery we do? Hysteroscopy and BSO. Hysteroscopic and bilateral salpingo-oophorectomy. Okay. Now we will do this surgery. Okay. Now if it is a ovarian tumor and tumor marker is positive, you suspected the ovarian tumor. Okay. 25-year girls come to you with adnexal cell mass. You suspect that this is dysgerminoma. You send the germ cell tumors, AFP, HCG and LDH. LDH was raised. You ovarian tumor diagnosed. Now what? Surgical staging. What is surgery we do for the ovarian tumor? Debulking surgery. We will open the peritoneum, and wherever we find the tumorous zone, we will take out, debulk it. Okay. And we will send it to biopsy. See how late the biopsy is being sent. Till now we are telling it a tumor because biopsy was not sent. In ovarian tumor only Now it is not that we will only send that tumor for the biopsy. We will also send that ascitic fluid, retroperitoneal lymph node, and omentum. Okay, we will also send and ascitic fluid, retroperitoneal lymph node, and omentum. Okay, did you got it? Okay. Okay, it means if you are suspecting uh, uh, getting the report of tumors or carcinomas, then you have to do the staging. Staging is the next step. Clinical staging in the cervical punch biopsy, endometrial biopsy, surgical staging, hysterectomy and BSO, and in the ovarian tumor, we will do the debulking surgery, and we will send the three more biopsies, that is ascitic fluid, retroperitoneal lymph node, and omentum. Let's do the question. Left side ovarian tumor, HCG is 4, AFP is normal, LDH is raised. LDH is raised in dysgerminoma. एक बार just tell for me, when is AFP raised? York sac tumor. When is HCG raised? Non-gestational trophoblastic neoplasia. CIN3 on punch biopsy. What is the treatment? Leap. Conization? No. Hysterectomy? No. It is a pre-malignant lesion. Patient will be perfectly fine after leap. Colposcopy? No. No. Answer is leap. This is a question. 55 years old, para 3, live 3, obese lady. The lady was also hypertensive, presented with postmenopausal bleeding. Okay. Cervical biopsy and endometrium biopsy both was sent. Cervical biopsy, nothing came. And on endometrial biopsy, complex hyperplasia without atypia came. So it comes out to be pre-malignant lesion. Pre-malignant lesion. Okay. What is the treatment? As the family is complete, 55 years, para 3, live 3. So the answer is hysterectomy. If the family was not complete, if this lady was only 25 years and para 0, live 0, then the treatment would have been progesterone, because it is without atypia. Okay. Okay. Now in this one slide we will see how to stage the all the cancers. Okay. First of all, you should know what is the route of spread. Cancer cervix spread by lymphatic spread via lymphatics. Okay. So it's spread via lymphatic. So if this is cervix, this upper one is uterus, this is vagina. Okay. So where are lymphatics? This is cervix. So lymphatics are located here and here. So lymphatics are located downwards and radially. Okay. So stage 1 is if the lesion is limited to cervix. Every cancer stage 1 is if the lesion is limited to cervix. Okay. Right. It is stage 1. If the lesion is limited to cervix, it is stage 1. If it is limited to organ. Stage 1A is if that lesion is very small, which cannot be seen to naked eyes. So it means its size is less than 0.5 mm. Its size is less than 0.5 mm. So the lesion which cannot be seen with the eyes is the micro lesion, and then that is the 1A, and 1B is more than 0.5 mm. 1B is 1B is, yes, 1B is more than 0.5 mm. Okay. Stage 2 is, now the we have come to stage 2. Now the cancer has spread, it has gone away from the cervix stage. Now it will go radially and downwards. Okay, because lymphatics are downwards and radially. Now if it upper two-third of the vagina is involved, then it is stage 2A. So here, whenever you forget, I always tell you make a circle. If in and dissect the vagina into two part. If it is in the first, if it is inner to the circle, it is stage 2. 2A is up this upper two-third vagina, and stage 2B is this parametrium involvement. 2A is this upper two-third vagina and 2B is parametrium involvement. Okay, what is stage 3A? Stage 3A is outer to this circle. This is lower one-third vagina and up till pelvic wall. This is 3B. Okay, parametrium up till pelvic wall. ठीक है, and 3C is paraortic and pelvic lymph node. Okay, stage 4 is the regional metastasis in the bowel and the bladder, and stage 4B is metastasis elsewhere. Okay, now the endometrial staging, the route of the spread of endometrial carcinoma is direct. Direct spread means organ to organ. Organ to organ. Okay. So what is the direct spread? Organ to organ, right? Stage 1A is limited to endometrium and less than 50% of myometrium is involved. Stage 1B is more than 50% of myometrium is involved. Now you see, this is the uterus and this is the endometrium. If it is limited to endometrium and half of the myometrium, then it is stage 1A. And if it is also involving this myometrium, it is 1B. Now stage 2 is organ, next nearby organ is cervix. So this is stage 2. Okay. Now stage 3 is serosa. Now this serosa is stage 3 plus the adnexa. These both are stage 3A. And the vagina is 3B. Always remember the vaginas are in which stage. Okay. So in CA cervix, 2A is upper two-third vagina and stage 3A is lower one-third vagina. In cancer endometrium, stage 3B is vagina, and stage 3C, 4A and 4B are same like CA cervix. Okay. There are high chances that cancer ovarian staging will not be asked. Okay, so I'm just giving you a limited idea. Okay, cancer ovary is spread by cavity spread. If it is limited to ovary, it is stage 1. If it is gone into the pelvic cavity, so they can ask you pelvic nodes, they can ask you uterus, adnexa, then it is stage 2. And if it is gone into the abdominal cavity, it is stage 3. And if it is elsewhere in the body, it is stage 4. Okay. So now let's do the question. Endometrial cancer with vaginal metastasis. What is the staging? So I would like to tell you, if this is the uterus, okay, and this is the endometrium. So 1A is half of the myometrium and 1B is the another myometrium, right? Stage 2 is cervix. Stage 3A is serosa and adnexa. Stage 3B is vagina. 3C is pelvic and para-aortic lymph nodes. 4A is bowel and bladder, and 4B is distant metastasis. So answer is stage 3B. And in the CA cervix, upper 2/3 of vagina is 2A, and lower 2/3 of vagina, lower 1/3 is 3A. Okay. Now let us see lymphatic spread of CA cervix. Now you know that the lymphatics are CA cervix spread by lymphatics. So you should know what are the lymph nodes which will be involved. So we have to take the biopsy. Okay. See, lymphatics which supply the cervix is HOPES. The mnemonic is HOPES. Okay. H stand for hypogastric. Hypogastric. O stands for obturator. P stands for paracervical, parauterine, or it is also known as ureteric. ठीक है. E stands for external iliac, not inguinal, iliac. S stands for sacral. Okay, S stands for sacral. So now obturator is the most common. Okay, and the obturator is the most common, and this is the first lymph node, P, or sentinel lymph node. Okay, let's discuss the treatment. Okay, now you have to remember two words. For CA cervix you have to remember 2A. For CA endometrium and CA ovary you have to remember 1A. ठीक है. So what is this 2A? Just a minute, I will. Yeah, here. ठीक है. For CA cervix you have to remember 2A and 1A for CA endometrium. Up till 2A surgery is sufficient. Up till 1A surgery is sufficient. Up till 1A surgery is sufficient. As you know that we do in the CA endometrium, we do the surgical staining, and in the CA ovary we also do the surgical staging. So if on the biopsy report of the CA endometrium and CA ovary, the staging has come to be 1A, because biopsies will tell us the report. If it has come out to be 1A, then no other treatment is needed. Okay, and in CA cervix we were doing clinical staging. Now if our clinical staging has gone only up to 2A. What was 2A? Upper 2/3 vagina and cervix involved. Only that much is involved. Okay, then we will do the surgery and the patient will get okay. What is the surgery we do? Of course, we will do the hysterectomy if the family is complete. And if the family is not complete, then we will do trachelectomy or conization. Okay? Okay? We will do the conization or trachelectomy if family is not complete, and if family is complete, we will do the hysterectomy. Okay? Now, other treatments I have to tell you. Okay, this was about the surgery. Okay, In CA cervix, we were doing clinical staging. If our clinical examination has told that it is 2A, then we will do the hysterectomy or trachelectomy, depending on the family is complete or not. And if we have found 1A after the surgical staging, then no treatment. And if we have found CA ovary only limited up to that organ, then no other treatment. Okay. Now, if the CA cervix is beyond 2A, means it is 2B and 3A, 3B, 3C, 4A, 4B, then chemoradiation is the treatment. Listen carefully. Chemoradiation can also treat stage up from stage 1 to stage 2A, but always surgery is preferred as compared to radiotherapy. Okay, because radiotherapy has lot of side effects. So radiotherapy is the treatment of all the cancer cervix stages, but always surgery is preferred because surgery has got less side effects and radiotherapy has got large side effects. Why we are not saying radiotherapy, why we are saying chemo radiations? Because when we give a chemical agent before the radiotherapy, it sensitizes the tumor cancer cervix to increases the sensitivity of the cancer to the radiotherapy. So we always give chemo radiation. Okay, we don't give only radiotherapy. First we give a IV chemical agent and then we give radiotherapy. Only chemical agent will not do anything. So chemo radiation is the answer beyond 2A. Chemo radiation. Okay. Okay, only chemotherapy will not do anything. In CA cervix beyond 2A, what is the treatment? For 2A, you know that it is surgery, and more than 2A, it is chemo radiation. Okay. Then beyond 1A in the cancer endometrium, it is radiotherapy. And in the cancer ovary beyond 1A, it is chemotherapy. Okay, this is the treatment of the cancers. Okay, now you see we are saying it cancer ovary because now we have done the biopsy. Okay. Okay, now one thing is that at this cancer ovary, all tumors are radio resistant. That is why we are giving chemo except this germinoma. Okay, ovary is the most radio sensitive organ in our body, but the ovarian tumors, they are radio resistant except this germinoma. But once this ovary gets tumorous, then it gets radio resistant. Okay, now let us see endometrium carcinoma stage 1B. For endometrial carcinoma and ovarian carcinoma, 1 till 1A it was surgery, and beyond 1A in the endometrial carcinoma it was radiotherapy. So answer is radiotherapy. Easy. Ovarian malignancy, all is done except debulking. Yes, we do debulking. No, when we do surgical staging. IV chemotherapy. Yes, chemotherapy we go beyond 1A, we give chemotherapy. Right? And intraperitoneal chemotherapy, yes. Radiotherapy, no, they are radio resistant. Next is 55 years lady with cancer cervix stage 3A. For cancer cervix, we have to learn 2A. Beyond 2A, we have to give chemo radiation. Okay. So answer is CT is chemotherapy plus brachytherapy is radiotherapy, which is known as chemo radiation. Here in the option, chemo radiation was also written. Okay, so that was all about the tumors. Okay, our oncology is done. I hope it cleared your concept. See you soon in the next class. Thank you. Have a nice day.